For the next session, I invite the chairpersons, Dr. Sriram Rajgopal, Chief Cardiologist, Southern Railway Headquarters Hospital, Chennai, Dr. C.C. Paes, Professor at KIMS Mangalore, and Dr. Shrikant Gadvalkar, Professor and Head of Department of Medicine at Vishveshwara Institute of Medical Sciences, Bellary. I invite Dr. Narasimhan onto the dais to speak on the role of ECG in pre-operative patients. I request the chairpersons to introduce Dr. Narasimhan.
Good evening, ladies and gentlemen. Important topic which will be told by Dr. Narasimhan, who is the director of EP Care Hospital. The topic is role of ECGs in pre-operative patients.
Thank you, Chairman, ladies and gentlemen. In the interest of time, what I thought was I'll compress my talk and allow a little more time for interaction. The whole purpose of this meeting is to just have some interactions. I'm not sure that we can elaborate on every single point. So I would like to compress the talk and have a little more on interaction. Regarding preoperative evaluation, there are repeated questions about ECG. Is this enough or should we do more? As a good clinician, we should realize no single test is perfect. We should know the strength and the weakness and the limitations of a test, and that's what we need to address. So first is to assess the patient and the clinical features, evaluate the functional status. This is extremely important because with increasing age, coronary artery disease, stable coronary artery disease is going to be extremely prevalent in the population, and these patients are going to require surgery for common surgical problems. Consider the patient's surgical specific risk. For example, a patient with a minor endoscopic procedure has very little risk compared to an aortic surgery, which the patient has a very high risk. And you should interpret the ECG in light of all the findings, not in isolation. Please remember, that is the difference between an ECG technician and a clinician. So what is the current recommendation of a preoperative 12-lead ECG is class 1 recommendation for patients with recent onset chest pain or ischemia equivalent, or who have clinically intermediate or high-risk patients. I'll come to what these high-risk patients are, who are scheduled for an intermediate or high-risk operative procedure. We are talking about the intermediate or high-risk procedure or the intermediate or high-risk patient. So patient-specific factors and surgery-specific factors. Class 2A in asymptomatic persons with diabetes. Class 2B patients with prior coronary revascularizations, asymptomatic male more than 45 years old. Now these are all things where you should pause and there has to be some commonsensical approach about this. For example, this was formulated in the Western society where coronary artery disease, triple vessel disease is highly prevalent in the 4th and 5th decade. If you look at Indian population, the whole thing shifts a decade earlier. You can ask me, is there data? Yes, there is enough data about the prevalence of coronary artery disease. We are likely to see in younger patients, so we may move the bar slightly lower. So first, let's look at what are the clinical predictors. Patient-specific predictors are simple clinical questions that you ask a patient. Whether the patient had recent syndrome of an acute coronary syndrome, recent myocardial infarction, or decompensated heart failure, or uncontrolled brady or tachyarrhythmia, or presence of severe valvular disease. So if a patient has any of these severe valvular disease, let us go from endocardium to epicardium. Valvulitis is endocardium. Endocardial valvular disease, muscle dysfunction, on the epicardium coronary artery disease, on the epicardium conduction system. So you have conduction system disease. Any of these, if they are present, then even if a patient has a moderate risk procedure, you would like to risk stratify or treat the patient adequately. On the other hand, if you have patients who have minor ECG abnormalities, who have just history of limited functional capacity because of an orthopedic problem or uncontrolled systemic hypertension, they come as minor risk indicators for risk of surgery. Risk is a very, very difficult thing to define. It depends on the environment where you're practicing. Similarly, you have high-risk procedures. For example, any emergency surgery in an elderly person, an aortic valvular surgery, or where there is a major vascular shift. This is extremely important when you ask a surgeon, when they open up the belly and you have fluids coming to third compartment frequently, you will have a patient with stable coronary artery disease, but he can become unstable because of the nature of the illness. On the other hand, there are low-risk procedures like endoscopic procedures, cataract surgery, which doesn't need an intensive evaluation on the part of the physician. So let us just concentrate on electrocardiographic findings of high risk. High risk in terms of unstable coronary syndromes, uncontrolled arrhythmia, and features suggestive of valvular heart disease. I would like some of the postgraduates to take part. This is, what do you think is the ECG showing? Patient comes for surgery, the ECG comes with this. It's an acute infarction. So in this patient, if the procedure is going to be an elective procedure, you're going to put a hold on the procedure and treat the infarct first. On the other hand, if he has got a bleeding peptic ulcer, you need to take care of that, which are equally life-threatening. What is this? This patient is admitted for ruptured appendicitis, blood pressure is 70 systolic, on dopamine and norepinephrine. Would you give him IV amiodarone? Would you give IV diltiazem or direct current cardioversion? This is a surgical emergency. Your role as a physician is to get this patient in the best of shape to the anesthetist so that surgery can be safely done. And what is the quickest way you can do is a cardioversion. Right? Take the anesthetist's help, make sure that the belly, his adequately airway is protected, and cardiovert the patient. Once the sinus rhythm, there is no question, in an unstable situation, an arrhythmia has to be brought back to sinus rhythm, and there is no faster way of bringing it other than a direct current cardioversion. Now, this is a patient who is admitted for a renal stone surgery, and this is the electrocardiogram. You see lead 1, 2, 3, AVR, AVL, AVF, V1 to V6 here. Would you get a CT pulmonary angiogram? Would you get an echocardiogram or a chest X-ray? What do you think is the finding? Patient who comes in, walks in for a routine procedure, you're very right. This is compatible with pulmonary embolism. There's a right axis deviation, monophasic R. Usually when you have pulmonary embolism, you have an incomplete right bundle branch block. This kind of a monophasic R, everything, this patient actually had a severe valvular disease, mitral stenosis with severe pulmonary hypertension. So an echocardiogram will solve the problem of making a diagnosis. After that, you need to decide how to stabilize the patient before you send the patient for surgery. Now, even if the patient needs a laparoscopic procedure, if they have severe valvular disease, you need to stabilize the patient before sending the patient for surgery, and you will probably optimize the hemodynamics before you send him for surgery. 56-year-old lady for lap cholecystectomy with an episode of vomiting, abdominal pain, and sweating. This is the electrocardiogram, lead 1, 2, 3, AVR, AVL, AVF, V1 to V3, V4, V5, V6. Would you go ahead and give clearance for surgery on beta blockers, check for tropi, do a CAG, or do a stress testing? Okay. Exactly. Someone said it right. Horizontality of the ST segment. When you have an horizontality of the ST segment, when there is a sharp takeoff, you see this. Shamroth used to call this as, Colin Shamroth, it hugs the baseline. It hugs the baseline and there is an abrupt takeoff. This is one of the earliest signs of an ischemia. Remember, patients with right coronary ischemia can present as abdominal symptoms, predominant visceral symptoms, vagal activation. They will have episodes of vomiting, diaphoresis, and hypotension. So you'll be barking at a wrong tree by operating a gallstone which is not responsible for the symptom, whereas the symptom was all related to an diaphragmatic irritation due to an evolving inferior wall MI. So the answer is to check for a tropi and keep the exclude a ongoing coronary syndrome. And the mistaken belief that the laparoscopic procedures are less invasive than the open procedures is borne out. You see that the laparoscopic procedures guidelines indicates have a similar cardiac stress and similar to open procedure, therefore they need a similar attention in terms of risk stratification. 72-year-old patient, hypertensive, for hernia repair, echo shows mild left ventricular hypertrophy. What would you do next? Exercise stress testing, coronary angiogram, adenosine thallium, or clear him for surgery? Yes? CAG, exercise stress testing. I think this, coronary angiogram gives you an anatomical information. What determines the outcome in surgery is the functional ischemic burden in an individual. So, and that is amply, it can be assessed by a stress test. Please remember, you cannot do a stress test, a regular exercise stress test on a person with a left bundle branch block, because you'll have false positive results. And the stress test of choice is pharmacological stress with either dipyridamole thallium or adenosine thallium. So you should know how to risk stratify a patient. If it's a minor surgery and the patient is otherwise functional class is excellent, then you may choose not to do anything, because you may be putting subjecting him to greater degree of investigations which doesn't actually translate into clinical benefit. So if a patient needs a non-cardiac surgery and it's an emergent surgery which is going to kill the patient, for example, a bleeding peptic ulcer or a ruptured appendix, just optimize the hemodynamics, accept the risk, and first take care of whatever is life-threatening. At the same time, perioperatively, you can manage the patient. Please remember, this is not, when you evaluate a patient, you should not be in isolation. You should be always talking to the anesthetist and the surgeon, because it's not one man's job anymore. So if you have a person, on the other hand, with high-risk clinical indicators like unstable coronary syndrome, decompensated heart failure, or significant arrhythmias or valvular heart disease, in these patients, as far as possible, if the surgery can be delayed, it's better delayed, optimize the hemodynamics, correct the ischemia, and then get him to a more suitable state before you send him for surgery. On the other hand, if you have a patient who doesn't have high-risk indicators, they are like compensated chronic coronary artery disease, old myocardial infarction, class 2 heart failure, presence of diabetes or renal insufficiency, in these patients, if the surgical risk is low, it is deemed that you don't need to risk stratify the patient. They can be cleared for surgery directly. On the other hand, if you have a person with an intermediate clinical risk, but a high-risk surgical procedure, for example, an aortic surgery going on, such patients need a non-invasive testing, or if they are very high risk and if you have any doubt, straight away consider a coronary angiogram. So in what are the situations where you would do a stress testing? It's recommended for patients with high-risk surgery, patients with 3 of the clinical factors which we already alluded to. If they have, it's a class 1 indication, or if they have high-risk surgery and 2 clinical factors, they like compensated heart failure and old coronary artery disease or old myocardial infarction, and stress testing may be considered to be indication in intermediate risk surgery, so on and so forth. Now please remember, the ultimate thing is, okay, you do a stress test and you find that it's going to be positive. Are you going to revascularize this patient and then send him for a surgery? If he's an old decrepit person who is unfit for anything else, then don't put him through all these things. You need to accept the high risk and clear him for surgery. So what are the high risk indicators? If you're able to have ischemic changes at low levels of exercise tolerance, less than 4 meds, if you have horizontal ST depression, which is present in 5 or more abnormal leads, and it's got typical angina during exercise, and it's persistent during the recovery period, these patients are considered to be at high risk of a large area of ischemic burden, and they need to get revascularized. Several of these patients who go for surgery may have minor electrocardiographic abnormalities, and they may not be fit enough to undergo a formal stress testing, exercise stress testing. And this is where a dobutamine or a pharmacological exercise test, like you give a dobutamine and look at the wall motion abnormality at peak dobutamine stress. And if it becomes abnormal, you feel that this patient has a provocable ischemia and he would require further evaluation. Some of these patients who are on beta blockers, for example, for their chronic angina or hypertension or heart failure, you need to continue the beta blockers. And please interact with the anesthetist all the time, because there are certain situations. If a patient, for example, is on clonidine, if a patient is on one of the alpha blockers, it is when you withdraw the patient, when the patient is NBM by mouth, that is when you will have a rebound hypertension. When you have a person with significant coronary artery disease which is stable, when you stop the beta blocker, the day 2, day 3, that is when they'll have a recurrence of events. So you need to constantly interact with the surgeon and the anesthetist to avoid fluid shifts and maintain their hemodynamics throughout the perioperative period. So risk assessment is, in terms of most important than the ECG even, is functional capacity, the urgency of surgery, and the risk as far as the patient characteristics are concerned, and the risk of the type of surgery itself. So what are the high risk indicators? Presence of coronary artery disease that is severe, decompensated heart failure, decompensated or uncontrolled arrhythmia, or significant valvular heart disease, especially obstructive valvular disease. Now, having said this, there are always guidelines or only guidelines. Some of them are not truly coming up in guidelines. Let us see this example. 16-year-old student suffered a bike accident, polytrauma, is posted for surgery, is diagnosed to have hemoperitoneum, blood pressure is 100/70. I'll show you the 12-lead ECG subsequently. He is young. Nevertheless, because of the unstable status and the patient is going for a high-risk procedure, an electrocardiogram is done, and this is what the electrocardiogram shows. Okay? On examination, vitals are normal, short mid-systolic murmur in left sternal border. The ECG changes are due to myocardial contusion, and therefore you obtain a TROP-T, dissecting aneurysm of aorta, get a CT angio, get an echo to confirm hypertrophic cardiomyopathy. What would you do? Exactly, it's hypertrophic cardiomyopathy. Echo did confirm that the patient had a hypertrophic cardiomyopathy with a 30 millimeter outflow gradient. It was taken up for surgery. While after pre-medication and during induction, patient develops hypotension, started on dopamine, and then this is what happens. Develops cardiac arrest due to VF, and what do you think could have prevented this? Intravenous nitroglycerin, hydration and beta blocker, IV dobutamine and verapamil, which one could have prevented this? Exactly. These things they are not mentioned in guidelines. A patient below 40 years of age doesn't need an ECG. But on the physical examination, you have a faint murmur, you have a brisk pulse, dicrotic pulse, you do an ECG, find these changes. Hypertrophic cardiomyopathy, for some reason, is highly prevalent in certain pockets of India. Like coastal Andhra Pradesh, we see very often. And these patients, when they go first, they are quite stable till they have preload changes or afterload changes. You find that these patients, when you give an ionotrope like dobutamine or dopamine, you find a significant increase in their outflow gradient, which precipitates an ongoing ischemia and precipitates VF in them. So a patient who has been stable can be made very unstable because of poor preoperative assessment, and they don't come in guidelines. You need to use common sense medicine here rather than just following guidelines. Majority of patients it's useful. So for high-risk surgery, which are aortic, vascular, emergent surgery in the elderly, or patients who are likely to have marked fluid shifts, you need to classify them as high risk. And in these situations, it's important as a physician to review the patient data, history and physical examination, and then cone down on the ECG and interpret the ECG in light of clinical findings. And if it is deemed necessary that an intervention is going to be necessary before you're going to clear for surgery, only then do provocative testing, recommend treatment to improve the overall medical condition, and preoperative testing is recommended only if it will change the surgical care or perioperative medical therapy. Thank you very much for the patient listening. I'll be able to take some questions.
Thank you, Narasimhan, for a brilliant talk, as always, very clinically focused. He specifically said he wanted interaction. And I see we have some time, so we invite questions from the audience.
Very good. Diabetes comes as an intermediate risk factor. You're absolutely right. It's a CAD equivalent. If it's a minor surgical procedure, like an endoscopy or a hernia, and the patient's effort tolerance is good, we don't recommend anything. We can take him up for surgery. On the other hand, intermediate clinical risk with high risk clinical surgery, I mean, patient is going to go for a high risk vascular surgery or something of that sort, yes, we will do a provocative testing. The problem is the very nice meta-analysis on perioperative use of beta blockers, and not all beta blockers are the same. As you know, what happens are two things. One is the patient's central aortic pressure has to be maintained. The second thing is the heart rate has to be maintained. Certain drugs, for example, like atenolol, do not bring down the central aortic pressure and may not confer the same benefit as the other drugs like bisoprolol or nebivolol used in the perioperative period. So if you have a patient with high risk vascular indicators, or patients with coronary artery disease, heart failure, angina, or patients who have been on prior beta blockade, they need to continue the beta blocker during surgery. Whereas a priori you wouldn't like to start a beta blocker on a person who is otherwise stable, who doesn't have any other problem and is a low risk candidate. There is some concern. I think some of you might have read Frank Mazzarli's article, meta-analysis. In some subsets, there has been an increase in mortality. So if a patient has absolutely no vascular risk, then I would be a little hesitant to give him a beta blocker. I think so, because for example, if you want to, there is something called Six Sigma in which most of the industries operate to reduce their error rates to as low a rate as possible, preventable error rates. If you have that degree of standard, I think we should have a defibrillator standby in every single patient. I was afraid that someone is going to ask this question because honestly I don't have an answer, and I did look up